Thank you, Dr. Deepak. Thank you, Arindam, for joining, and thank you, everybody. Before we start our panel, just 1 minute I'll take that. We all know that in first and second wave, we did not have enough information to handle the situation. And that's the reason we lagged behind the disease. Purpose of this webinar, what we are planning is that at least we should be ready, whatever information we have to handle the situation which is upcoming. As we have seen, wherever third wave had knocked up, the severity of disease is more, younger population is getting involved, and mortality, as is being predicted, is being very high. So for preparing third wave, we need to have a 360-degree approach, right from the public, government, hospital, and all healthcare workers. What light the tenets of the disease is, if we can prevent and prepare for upcoming problems, that will be better than preparing our hospital and ICU for cases and managing them. Because we all know the disease is unpredictable, and second wave has shown us that it has got very high mortality. In fact, some of our doctors has got so much of trauma that they needed some rest for some time because of the kind of psychological stress they have undergone. So our total intent and total motto for this webinar series is, here we are going to have today a broad guideline, what we will be probably doing in general, and then in subsequent webinars, which is going to happen in coming week, where each and specific topic will be discussed. So at least we can have a rough idea what we are going to do that. So with this, I'll just start with Dr. Xavier. Dr. Xavier, my first question to you, that whatever we have learned from wave 1 and wave 2, how we are going to implement, particularly about public behavior, what specific we should be doing. That's why we can prevent the disease in public, because the moment the second wave is gone, at least what we are seeing again, public is getting relaxed, they are coming to their normal life. The new normal probably still people are not able to understand. So what should be done? What is your thought in general for across the world, not particularly for our country, across the world? What should be public behavior? That's why we can contain the disease and we can prevent the disease.
Thank you. So unfortunately, I think that public behavior is parallel to authorities' recommendations and ordinance. And we're seeing not only that the public is getting relaxed on some of the aspects, but also that the authorities are relaxing the protective measures. So we're seeing that, and we're also seeing a little bit of a revamp on the number of cases here in the US and also in European countries as we relax more the measures. So I think we need to continue very strong education efforts and public awareness. The pandemic is not gone, and not even in those places where the vaccination has reached very important numbers, such as the US or other countries. We're still having significant number of cases, and we're seeing, unfortunately, that people are going out and they're getting together and they're not keeping their mask on, and they are getting close to each other, and they're actually promoting activities in which there's significant crowds involved. Second point I think is very important, and I know that we are going to touch that in a second, is to make people awareness of the importance of a universal vaccination. So if people don't get vaccinated, what's happening is that we don't reach the herd immunity. What's going to happen is, unfortunately, we're going to find new variations of the virus, variations that could be potentially resistant to the immune system that we are created through the vaccination. And we're going to see a non-ending story about this. So we really need to make people aware that vaccination is not only for you, it's also to protect your beloved ones. It's also to protect the community where you live at. I think that those 2 points are really important to highlight in the next few weeks.
Okay. And Dr. Khilani, sir,
yes, sir.
Your specific find from you, if you have to give one message to everyone, the new normal life for Indian public or public across the world, what will be your suggestion to prevent the third wave?
If you give me 2 minutes, I want to say something.
Sir, you have 3 minutes.
You have to look at a few things. It's very easy to criticize public, and we keep criticizing and nothing happens. But you have to look at a few things. Number one is the virus. The virus is changing its behavior We had a R naught of 1, now 2.2. Now, God forbid if this virus R naught becomes 4.5, that will be a troublesome thing. People's behavior is one thing, and third thing is herd immunity. As far as India is concerned, India is not Delhi or Mumbai or Ahmedabad, or metros are not India. India is a very big. If you talk about Delhi, we have a zero prevalence of 79%. If you talk of villages, zero prevalence is, I guess, is extremely low. Currently, we are having calamities in the places where the disease did not reach before. So therefore, the second wave, third wave, and to my mind, the second wave has not yet gone. Second wave is still going on. It has gone to the villages. So therefore, third thing is that whether the next mutation would evade immunity by the vaccine, and that's a big threat. If the next virus evades the immunity, so these are the few points which are extremely important. We can keep criticizing people. You cannot change people's behavior. We have been shouting on television and here and there. Nothing happens. You talk about want a room in Shimla today, you cannot get. People are holidaying, but I'm not criticizing them. The correct situation is that we have to be prepared. We need genetic map up of where the virus is coming from, where the spurts are going. We have to contain them. That is extremely important. The surveillance is extremely important. And even if I talk about UK, per population, they have vaccinated a large number of people. Still, UK per population cases are much more than India. So these are few points that I want to touch upon, and whatever you would ask, I would.
Sir, excellent point. In fact, I will take it further from your queue only. And Dr. Rao, sir, Dr. Kilani, sir, is very specific about the surveillance, because we know that whatever prevention we take, everybody tried, but it did not work. So one thing is the surveillance and changing behavior of the virus and control. But what I can understand from his point is trying to control the source. If we somehow we can make extra personal surveillance and control the source, that will be a better way to control the disease rather than controlling people behavior, and probably a mass vaccination and trying to achieve a herd immunity, which is also looking a difficult target. Looking to the condition where virus is changing its strain so frequently, and to match up with that is getting a vaccine is not easy. So what is your thought on that? Dr. Rao, sir.
No, it is absolutely. Can you hear me now?
Yeah, we can hear you, sir. We can hear you, sir.
Okay. See, in the first one, when we went for lockdown, we very soon realized that locking down the nation is not the answer.
Exactly.
You've got to monitor where this is coming up, where are the pockets, where the new strain is emerging, and that's the area you should isolate. So it could be a town, it could be a small locality, it could be a building, whatever, but selective lockdown is the answer. And if you want to do that, you have to do the surveillance part. The monitoring, genetic genome monitoring has to be done. Then only we will know, like it happened in Kent, in UK. I mean, in retrospect, we know where it came from. So it has to be done in the live environment rather than retrospectively. And then by the time it has spread all over.
Okay. Kapil, question to you. So now we have three options of containing the disease rather than four. One is controlling public behavior, putting a strict lockdown. Third is the option of putting a surveillance, a strict surveillance, which is like not in our hand. If you need a lot of resources for that, a lot of government and public cooperation. And fourth is mass vaccination to achieve herd. Do you think any of them or all in together is going to help for third wave, and how we should implement this strategy? Because what Dr. Kilani sir and what Javier and what Dr. B.K. Rao has suggested, that it's not, at least what we can get is not one strategy which is going to work to prevent the third wave. We need to have a combination of 360-degree approach to prevent the disease. What is your thought on that?
Rajesh, if we have learned from the first and second wave, why we had such a worse second wave? Because we let our all guards down. That means there was no COVID appropriate behavior. Government, private, everybody was relaxed and they were very happy with the containment of the first wave. Second thing, variant has changed, like Dr. Khilani rightly said, that the virus is also smart, it is changing its behavior. Third is vaccination. We hardly achieve 5 to 10, even 5% of the vaccination. And fourth thing, we just forgot that art of surveillance, contact tracing, testing, quarantine. So these are the so important part of the any virus. Like Dr. Khilani said, the R0 factor. What is R0 factor? Initially it was 2 to 2.2. Now it is jumped to the 5.7. I still say that Dr. Khilani said it is not jumping, but it is already jumped to the 5.7. So if with such a R0 factor, if we are lacking on every this thing, if you do not want to go ahead with the third wave or worse third wave, you have to act on every step. Like whatever we did mistakes in during the in between first and second wave, don't let your guard down. Public as well as the even some restriction lockdown, not fully lockdown. I agree with Dr. Bikra, but not even open up. Like at least malls, restaurants, and those social gathering places should have some restriction. Second thing, the aggressive vaccination has to be done to achieve that 70-80% of the herd immunity. Third thing, we need to see that those pockets like Pune and Mumbai is saturated. If you see the seropositive survey of yesterday, which was declared by the PMC and PCMC from area, 90% is a seropositive rate. So already majority of the population in Pune, Mumbai is infected or achieved through the vaccination, or they had developed the antibodies. So we should now decentralize ourselves from the metropolitan cities to the villages or those remote areas where this virus is still active and that population is not exposed to this virus. So this combination of the everything, every agency, whether it is a government, whether it is a private, whether it is a public, or whether it is a epidemiology team, they should work together in communication with each other. Then only it is possible to get the less severe wave. One should understand that waves are not going to, this coronavirus is going to stay with the lifelong. We just only interested, it should not reach to the peak like a second wave we have observed. It should not give a surge within 2 months and then whole healthcare system, this thing. So I agree with you. First thing, the public behavior. Public needs to learn. There is no excuse. We should criticize heavily on the public behavior and those government authorities who are following that public behavior. COVID appropriate behavior must. Second thing is the vaccination as early as possible, as rapidly as possible, as much as population. Third thing, surveillance, contact tracing, testing, and quarantine on aggressively. And the fourth thing is reach to the now remote area. This is where we are going to control the virus. It is not going to get out. That is what my stick with this.
Sumit, I'll come to you for two questions. One is the public behavior and second is the vaccination, because other things are not something which we can, particularly surveillance, you need a lot of planning and about quarantine also. But one is the public behavior and second is the vaccination, where it is like that. This is one something which if it can be driven, it's achieved. So what do you think is the biggest hurdle to implement public behavior, and what is the biggest hurdle to get vaccination, particularly in our country? What is the problem we are facing?
Well, thanks, Rajesh. But I would also like to add a few more things. Public behavior does not come out of the blue. Public behavior comes out of a trust of a social government system, right? It comes out of a trust. You see, I mean, I keep saying that. I mean, we are looking at examples across the world, but look at the example of Kerala. It has been tom-tommed across the world. The reason being, what did they do right? Yes, the numbers are large, but they never got overwhelmed. They never got overwhelmed, and the mortality percentage is one of the lowest in the world. And the data has not been hidden there, right? So the reasons are 3 or 4. One is public behavior is improved by involving the community like they did. From every PHC to sub-center, there were beds put, local people involved in volunteering for patients who had COVID, tracking and surveillance, everybody talks about, but involving the community in doing this increases trust. That's one way of doing it, okay? And the linkage, which I have spoken on multiple TV channels, is linking the patient who is in the community center to be moved. Those subset of patients who have to be moved to a higher center, it is the responsibility of the government to coordinate that. It happened to a certain extent in Mumbai, and that's why later they were much more successful. this is happening constantly in Kerala. The linkages between the lowest rung of the healthcare to the highest rung of healthcare is directed through the community and the government, right? Third thing is, people will stop. I'll give you a very quick small story. I went to my hometown, which is a very small town in Odisha, which is 4 hours from the capital, Bhubaneswar. When we drove through, there was a lockdown. No shops, nothing were open. How do people survive? Okay, that has to be taken care of. Only then people's behaviors will improve. In certain states, these people, everybody was provided with certain level of amenities, care, food, etc. Okay, I'm not talking about the Western world where the social security systems are much stronger, much more powerful. There's much more money in that country. I'm talking about a state in this country which is moderately well off. It could be done there. These are essential things which we have to implement to get public behavior also to improve. Public behavior is only one end of the thing. If we don't do these things, we look at shortcuts, we hammer people saying, wear mask, wear mask, wear mask. Lockdown is not going to happen. People will break those lockdowns because they have to survive other ways. You have to understand that. All these things put together will only improve how people's behavior improves. Okay, about masking, about behaving in lockdowns, etc. And education. It's a constant. It's a mix of things. I'm not saying there is only one way. There are multiple ways to do it. And these are the things which we have to look at. One thing which you are also forgetting is among the behavior things is ventilation, household and office ventilation. We have to improve ventilation in offices so that they can be opened up and people can work there, because it's finally absolutely an aerosol generating. The way we close our offices with glass and high, ACs, that is also long-term, and way we look at the environment and look at our office environment, work environment, and our environment at home, how we live has to change in the long run. All these things have to be done to improve or change people's behavior. So that's one thing. Vaccination, again, across the world, vaccination has been better. There will always be vaccine skeptics. Have been better where people have more trust in the government. Wherever there is more trust in the government, people are ready to go ahead and do it. Good public health systems, giving transparent data. You hide data, people are not stupid. Okay, people will keep asking questions. All these things are important.
Okay, thank you. Gloria, coming to you about the vaccination. So how much you believe the vaccine, which is whatever vaccine is available, if we vaccinate our so-called 12 plus population, 12 because it's not available, it's still for less than 12, so at least for 12 plus. So if you, what percentage of population you want to vaccinate to achieve the herd immunity? So say for example, in India, we have this much of population. So what population we need to achieve until we are able to achieve that herd immunity? What is your suggestion we should be doing to prevent this third wave? It's a very difficult question for you. I'll come from your input, I'll come to other panelists also for the same question.
Sure. Well, what has been said to achieve herd immunity is that you need your 70% of the population vaccinated.
Minimum 70, I mean 70 to 80. So like
70 to 80, but they're saying 70.
Yeah.
So that is something that you need to have a strategy, not only at a local level, which I think is very important with what Dr. Sumit Ray was saying, that you need to involve the communities, but you need to have a strategy on how to achieve it. And what we were talking earlier, you also need to have a global strategy on how to achieve this, not only local in your country, but also in your community, also in the world. If we don't get the whole world vaccinated, we're not going to get out of this pandemic, because then we're going to keep having variations coming about. And at some point, it will be resistant to the vaccine that we are having available.
Nitin, coming to you, since it's a pandemic, it's a global problem. We cannot still see COVID as an India-centric or state-centric. It has to be seen. So if I have to say that, if we look at a global perspective, where do you place the vaccine today? Because the strain is changing so fast. and how much we are confident that whatever vaccine we have, we will be able to pace up with the changing strain and we'll be able to contain the vaccine, contain the disease. So two questions to you. One is the what global population you need to vaccinate, and how frequently you need to vaccinate to achieve that herd immunity to contain the disease or make the world disease free. That's what the question is. Very hypothetical and very difficult question to you.
Yeah, you chose me to pick this one. Okay, so I think this is a question which is very similar to how many angels can dance on the head of a pin. I don't know, but what I definitely know is that I live in a place which is almost like the travel hub of the world. The UK is one of the top 3 international destinations in the world, and so there is no way that the country can open up properly without a fair amount of global response. Now, nationally, we are continuously hearing 70 to 75% vaccination or immunity rates needed to achieve herd immunity. If we think about it internationally, to achieve 70% global rates, it would take, when I last looked last week, it was a case of it would take over 2.5 years. Now, can we actually ban international travel throughout the world for 2.5 years? It sounds very, very difficult to achieve. I think we need to do something, and that something very likely is going to be more vaccines will come online. The existing vaccine production will improve, and we will see once, and again, I have a moral and ethical problem with this, but once Western Europe and North America have vaccinated everyone, then they will start releasing excess doses of vaccine to the other countries in the world. And hopefully then we will start seeing some more vaccine. Though, as Dr. Gloria was saying earlier, I have a moral problem with this. I think we should not start vaccinating under 20s or under 18s without trying to get enough vaccine doses to other countries where even the vulnerables, even people over 70 have not been vaccinated yet. So I think this is going to be a complex public health, financial, and moral and ethical dilemma. So I'm afraid I've talked a lot, but I haven't given you a straight answer. Sorry.
I'll go for the same question to Javier. Javier, would you like to take that question? How do you think this global problem with the vaccination, and how long it's going to take, and how we can make it faster? Because, you know, as long as the disease is not getting contained worldwide, even one country controls, it's not possible that everybody becomes. So it has to be disease. World should be disease free, and to make disease free, vaccine is a plausible option apart from other things. So how will you able to achieve that? How you can achieve?
Well, this is very difficult, and I agree with the previous speaker. It's going to be very difficult to ban traveling for 2.5 years. So the question is whether we can provide some tools to accelerate vaccination in areas of the world that are not being at the same pace that other areas. And I think this becomes an important issue. So it might not be science fiction to think about, you know, administering vaccines to travelers. And that might be an option as well, meaning if you arrive to a country where the vaccination is available, and maybe we are going to be able to provide the vaccination to those people who need to travel and have not been getting the vaccine in their country. And that's possible. Obviously, the utopic way to distribute vaccines everywhere in the world is something that we always talk about it, but I agree. I mean, it's going to take years to provide enough vaccination for people. So I think, I mean, number one, we need to make the homework at home. And that means we need to convince our own populations to get the vaccine. Number two, we need to consider the options to sharing vaccination resources, not only just the vaccine itself, but also the information resources and et cetera. And finally, again, is maybe a call to consider the same way that some countries are administering the tests upon arrival, whether you can do that as well with the vaccination. And again, this is something that we're learning day by day, and it's very difficult to make international policies that will be achievable for every country in the world. However, I think this is a humanity effort that we all have to make in order to control this pandemic.
Okay, Pradeep, very quick question to you. India has achieved a mass vaccination program, although it's not same, but at least for polio, we have done a mammoth task and we vaccinated the whole population. So, where do you place? What is the problem we are going to face with vaccination of COVID for Indian population, apart from availability? If suppose the vaccine is available, how long is going to take Indian population to get vaccinated to come back to the normal life? Because everybody is saying it's herd immunity. We all know that if we develop herd immunity, that's going to be one of the way to get back to the normal. Otherwise, it's not possible to control. So our total focus is on vaccination to prevent the third wave of subsequent wave. So how we can achieve in India? What is your thought on that?
If you look at the, am I audible?
Yeah, you are audible.
If you look at the WHO site, today I was looking at that site, it was showing how much population of India has actually got a complete vaccination. It is only 4.5%. 4.5%. And we started our vaccination program in the month of January. And at present, we are running the month of July. So suppose we have crossed 6 months and just we have vaccinated our 5% of population. That means we are going to take at least 6 to 7 years if we are going to continue with the same pace of vaccination for our entire population. So the current pace at which we are vaccinating our population of our country, it is, I think, very, very less as per the expectations or what the target we should achieve. We have to increase it. And currently, the way that every now and then you see that government is giving order that private organizations should stop vaccination, and they are not provided with the adequate number of vaccines and vials, and only the government organizations will give vaccines, and all these things, tantrums have to be stopped, and the vaccines should reach up to the district level, even the PHC level, to complete this process. Because otherwise it is very difficult, not be possible.
So, Khilani sir, you must have been part of so many government programs for vaccination, I'm very sure. So if you have to tell government that I want, like, take a hypothetical condition that in coming 3 months or 6 months, we want to vaccinate all Indian population. So what will be your 1, 2, 3, 4 point to tell government to do that?
Actually,
I'm not asking you it's a real, but just a hypothetical situation that how we can improve this. Not really, we cannot advise, we have no one to do that, but just actually, I'm asking a hypothetical situation that if we can achieve that.
See, Rajesh, whatever I say in this context will be superfluous because of one, that I'm not in a position to influence anything. Neither any one of us in this panel can do that. But if you permit me, I want to bring up a few points which are which are academic.
Yeah.
Now, all the experts are saying that vaccination does not prevent infection. At least the vaccine that we have, Covaxin, and I am associated with Covaxin trial, and this is the version of the chief of one of the centers, that it does not prevent infection. It at best it prevents the severity. That's true about Covishield vaccine as well as. So what we are left with? I'm not against vaccination. Vaccination is the key, but in long term, this disease is going to be endemic. We have not been able to eradicate measles. For God's sake, we are vaccinating every child, yet the measles is there. So this disease is becoming endemic. It is bound to become endemic in the world. We have to live with corona. Now, how we live with corona, that's a question for which vaccination is number one. I totally believe that vaccination is important. And I was hoping actually that we will reach 1 crore a day by the end of July. That was my optimistic, but it didn't have to happen. But none of us sitting in this panel has any control on that. But what we can do, of course, the vaccination hesitancy has gone. Now people are actually going after and struggling to get vaccination. Although Pradeep said that 4.5% are vaccinated, but in India, the total vaccination, about 35 crore have received, dosages have been given. So there is, it's not that pessimistic also as 4.5% as Pradeep has said. But the question is that vaccination is not going to be enough. There are going to be variants. Some variants have already shown reduced efficacy as far as the vaccinees immunity is concerned. So therefore, multi-pronged approach will have to be there. Besides vaccination, we need to understand that this wretched disease is going to be there around. So all the other things which other panelists have very eminently said will have to be said. But India has to enhance their testing facility and also genomic. The Delta wave has taught us, and this was the topic of the discussion. It took us very long time to realize that we are hit with Delta waves. So therefore, when the second wave comes, the third wave, whatever comes, it will be because of the biggest threat is going to be a mutated virus rather than, if Delhi is not going to get third wave because of the Delta virus or Wuhan virus. Delhi, if it gets a third wave, it will have to be because of a new virus. So unless you know that you are hit with the particular mutant virus, you cannot take preventive measures. That's my internal thought process I wanted to put across. Thank you.
Rajesh, may I intervene here?
Yeah,
Good evening.
yeah, sir. Yeah, sir.
Yeah, I've been listening. I was listening. I think a word of wisdom. If I give you a little insight in terms of the, if you permit me for 2 minutes of the way which hit us, all of us, at least in the north and the NCR, which Professor Kilani was also talking about, and Joseph and Dr. Rao was also talking. Till the middle of March, or I will say late March, we all were actually hit by the Kent strain, the so-called alpha strain. It was at that point of time when we looked at Haryana, Punjab, dominantly it was all Kent state. It was Delhi where we had a ratio of 60-40 which was coming up, 60% Kent strain, 40% Delta strain. And then middle of it, suddenly we find now everything is Delta strain. It practically has cleaned everything away. And that's what we are finding. And I'm saying it because I have the genomic data of my state. I have the genomic data which is coming up. I think variant of concern, variant of intent will keep on coming, keep on going up. Whether it can help us or not, yes, what we need to do is that suddenly we find that we have to clinically correlate, because three things you need to look at the virulence in terms of infectivity, one. Second, you have to see whether it is associated with increased virulence, 2 point. And secondly, are our hospital rates and admissions are going up? I think that is there. Unfortunately, what had happened was everybody was complacent and everybody was tom-tomming. That was one point. That is why we landed up with the problem. And you trust me, the numbers exactly are the same which were projected last year. I've been repeatedly saying on TV programs, other places, one thing very clearly. Last year it was lockdown. Last year we had blunted the curve. This time we were overconfident and with the supreme confidence blowing over the top, and we landed up the problem. Now the second thing which is important is the vaccination, fair enough. Now we are showing that irrespective of the thing, whatever the vaccines are there, they have efficacy, maybe little reduced, but nevertheless a significant efficacy. There not much reduction, including our own built in India, Atmanirbhar India Covaxin, for which, well, I am very happy to be a part, which I was a part of it and very proud of it. But unfortunately, a lot of politics and economics has come into it. Now, that is where the problem has started coming in. It's a financial thing which has started dictating the vaccine policy at large number of places. In India, under the pressure the government buckled, we increased the denominator. We started with about 55. We came down, let's say first we started with 65, came to 50. We have suddenly increased the denominator. And once you increase the denominator, obviously things have been there. We need to realize that universal program of immunization is going on among children. When we are saying corona is not the only disease. You look at the data which is there in the first wave and the second wave, no difference in percentage of people in terms of effective at the age group, in terms of other things. The only difference has been that what we saw over 3 months, or six, for which we were prepared, we saw over a period of 3 to 6 weeks. So what we have to be very careful, I agree, vaccination is the road forward. Looking at the population density, we may talk about everything about it. The only thing which is savior is if we can ensure is mask and double masking for the people. That is one thing I will do it. we are all talking about upscaling of testing. What more you want an upscaling of testing? In terms of Haryana, I can say from 250, we are doing 35,000 to 40,000 a day. Same is happening at other places. So it's theoretically very good to talk about testing. Testing is there. Tracing, again, I come back to the tracing. At my state itself, I again giving you data, is that in my state itself, we did a village program. In this second wave, once it has happened, we traced 1,73,00,000 people. And we picked up 1,23,000 of ILI, out of which we did rapid antigen testing. Nearly, we were able to detect 12,000 people having it. And then we did a rapid RT-PCR. We picked up another 1,500 cases. So the point is we are doing. There are certain states which have challenges which are there. It has to be a combined effort. But remember one thing, what Sumit was saying. Health now people should realize is not simply disease. It's the economics, it's the social structures, system, infrastructures that we have to see in public health.
Dr. Dhruv, I'll come to that. Dr. Dhruv, I'll come to that point. I'm just shifting the gear because we have talked enough about that thing. Yeah. Gloria, very quickly to you. Suppose now we get hit by third wave, and we know that the way second wave came overnight, and there was places were flooded everywhere. So same thing happened here. So how we should prepare ourselves to handle the patient, to triage the patient, whatever we have learned from wave 1 and wave 2, to reduce that anxiety and to reduce that, because what we have seen in second wave and first wave, that 90% of the patient even can be treated at home by simple paracetamol. 10% of those patients who were not anxious, just good monitoring has helped to reduce the hospitalization. So suppose we get hit, how we can convince the people, how we can convince the patient at large that most of the things can be handled at home by proper monitoring. So what should be the general approach to reduce the flooding of the patient to the hospital? I'll come with the question with every expert. What is your experience about that?
Well, one of the good things of being through the first and second wave is that now we know what works and what doesn't work.
Yeah.
We know more about the disease and the implementation. So I would see this as a threefold thing. One of them is the public response and educating the public on when to seek medical care. Like you said, most people are either asymptomatic or mild disease, and this can be managed at home. The one thing that the pandemic has shown us is that we can use a lot of technology. So we can use telemedicine, we can have calling centers, having somebody call, and you can do the screening over the phone. You don't have to go to the emergency room to get the screening done. And that type of information can happen. The other thing is within the hospital. Once those patients arrive, not all of them have to go to the ICU. Some of them can go to the ward and get treatment there, and then the triaging. And we have learned that there isn't enough intensivists or healthcare personnel to be able to take care of these patients. So we should have had time to train some of our colleagues to be able to assist in that. And then for the critically ill, that's where you dedicate your high acuity resources. The other thing that we should be also taking into account if we do have a third wave is we talk about ventilators, we talk about medications, but we don't talk about the humans that are involved, the healthcare personnel that have been on the spot since the beginning. These are the same people, and if you have mentioned, India has lost healthcare professionals to this pandemic. So we need to take care of those. If they show signs of burnout, try to mitigate that so that way they are ready for the next wave. In terms of the government response, the one thing, and we have all mentioned lockdowns throughout this conversation, and the way I see a lockdown, it's to protect the healthcare system so that it doesn't collapse. Because if you have a lot of people from that 15% that are critically ill going to the hospital, that's when you have the collapse of the system, and a lot more people will die that do not need to die. So if we do implement, and now that we have vaccination, and we don't lower guard, and we know what works. Masking works, vaccination, tracing. And if we do that implementation, then we don't need a lockdown, because 1.5 years into a pandemic, the economy is going to collapse, right? At the beginning, health trumped economy, but now, since we have other things, I don't think we need to do lockdowns every time we have something coming up. We need to do lockdowns to protect a healthcare system if it's about to fail. And then maybe you can just select places where you can do that. So that's one of the things that I thought would be to prepare for the next wave. Have your surveillance system, your hospital system and the response, and the education of the public, which I think is very important.
Great. Sumit, very quickly. So what will be your suggestion to manage the key resource? Key resource, when you're talking about, we know that we have seen the worst oxygen crisis. We have seen the ventilator crisis. We have seen all life-saving equipment crisis. So one by one, now we know that if third wave hits us, it may be worse than second wave. We need more oxygen than what we needed in second wave. We need more equipment what we needed in second wave. So how we are going to manage that? Because we have already reached to the peak of that resource management, I believe so. So how we are going to channelize more resources now?
Yeah, so Rajesh, I think, I don't think in terms of oxygen, we have reached our peak production. It has been mostly distributed. So there has to be things which has to be organized at the level of the central and the state governments coordinating. And you see, if you see the pandemic, if we look at our country, and I'm not going to go international at this moment, you see it has always never hit together all places, different parts being hit at certain points of time. So the central governments and the federal government and the state governments working together to see where the movement of resources has to move to the next level, next city. One is that. Second is the connection between the top to the bottom. The second is resources like ventilator production, etc., has to be managed at the center and the state level, and the movement of ventilators. Again, right, moving teams where this city has been hit badly, moving teams there, setting up prefabricated hospitals, escalating the bed strength. If that moment it is necessary for a 2-month period, that would be the other thing. Third thing would be what Bombay did: divide a city where metros are hit most, or if it's a district, etc., into certain sub areas. Distribution of resources, moving of patients between the sub area and between the larger area has to be done by the government, has to be coordinated by the government. As private players, we cannot do that. And we have to follow that. And that model worked well in the second surge in Mumbai. That's why Mumbai did much better than Delhi, or for that matter, Bangalore. So all these lessons are already there. How you move resources, who organizes and coordinates these resources, these certain answers are already there. There will be moments when we will be overwhelmed. And as Dr. Rodriguez said, that those are the moments where the systems are getting overwhelmed. Brief, tight lockdowns for moments to just stop the systems getting overwhelmed. The combination of all these has to work together when a next wave hits us. And the flexibility of government and us to shift things, change things quickly is also important.
Good. Pradeep, very quick question to you. We have seen that everywhere, the healthcare worker crisis, it has hit us badly, right from the nursing staff to people who are taking care of the patient. Particularly in our country, in other country, I will ask how did they manage? I will ask Dr. Javier also, how did they? So what do you suggest that if something happens? I don't see that we have dearth or deficiency of healthcare workers in my country. Probably we could not manage the resource, or we could not probably guide them, or we could not train them for this job. That's why we could not manage. So if you have to suggest something for managing healthcare resource, what is your input for that? And then the same question, I'll come to Dr. Rao also for the same question, because this is something very important for us now to manage healthcare resources.
Because in my state, Jharkhand, and what I did is that they asked me and I gave them that suggestion that anybody who is working in the hospital in the form of any kind of paramedic, any kind of, whether he is a lab technician, he is an X-ray technician, he is a ECG technician, or is anesthesia technician or OT technician, nursing from different disciplines. And from every hospital, depending upon the number of beds which is available or which they have created for COVID, number of staff should be defined, including the doctors, and they should be sent to our tertiary care center for training. And government has listened to that, and I'm telling you that for last 1 month, we have given training to more than 400 staffs in our state from different district hospitals and PHCs. They have come to our hospital and they have taken a training of 10 days each. And that includes a group of doctors from individual hospital, which consists of doctors, nurses, paramedical staff, as well as ward attendants. So all these a group, they in the form of group, they are coming to our tertiary care center and they are getting training and they are going back. And now they are ready to give services for food. And
Dr. VK Rao, sir, what is your input for managing? Because this is one resource which is probably going to hit us badly in any pandemic, and how we can optimize our resources. And another problem with the healthcare workers are they get burnout, they get fatigue, they can also get infection. So how we should optimize healthcare worker resources?
Without repeating what other panelists have said, let me add, it is a supply-demand situation. What we are talking is how to increase the supply. We must cut down on the demand. And if we can balance, and that is, we are talking of what we learned. We means the healthcare workers, the hospital, the policymakers. What have the patients learned? Patients have learned that unless you reach the hospital in time, that means very early, you may not get a bed. If you want oxygen, it will not be available, so stock it. Okay, so this is where the demand was increasing. We all know that 10 to 15% of the patients could, in the first place, didn't need the hospital or could have gone home. But they will not, because they know there are no doctors, there is no investigation which is possible. The drugs will not be there, the medicines will not be there. So they have learned it a hard way, that the safest place to be in is a hospital. So that demand has to come down. In the supply side, I can only add that digital technology, use technology, you can increase any number of people. You will still not meet the demand unless you use the technology to provide the care.
Okay. Nitin, your input about the same.
Right, sir. Can I say two things here? I think the previous speakers have already covered a lot of points that I had written on this piece of paper in front of me. But I think there's a couple of things I would like to expand on. One is staff. Now, with staff, as Dr. Bhattacharya said, before the second wave over here, we had a plan where we actually went out and trained about 20,000 what we called reserve ICU workers across the country, which was a combination of nurses and doctors from other wards. And some of them, most of them actually, we did not try and make them into ICU nurses or ICU doctors. We just trained them in specific tasks. So there were teams that were tasked to proning. There were teams that were tasked to do lines. There were teams that were tasked to actually just help do routine stuff, including making coffee for the nurses. British Airways actually gave us 270 cabin crew who actually did a lot of housekeeping work across the hospital so that our own housekeepers could be upskilled to come and look after stuff in intensive care, and where they were working as nurse helpers. So which then enabled us to increase our nursing ratio from 1 to 1 patient to 1 to 5 at the peak of the wave, because we had ward nurses, and actually 7 orthopedic surgeons were in the proning team. So it's not that it was just people, just lower paid members of staff or lower status members of staff. 7 orthopedic surgeons were part of the proning team, and it actually worked really well. And I think that is one thing that has not been done as much as we did over here. And this is one thing that could be done in India, which is asking other specialties for even more help. The second thing, which Dr. Ray partly touched on, is we've talked a lot about digital technology. We've talked about home monitoring. We've talked about getting people into hospital at the right time. But to do that, we need to avoid the panic, because if people think hospital beds are going to be in short supply, they're going to run into hospitals early. The other thing that we need to probably, one of the things that can be done is that regional coordination and a digital dashboard which shows live which hospitals have how many beds. And I know Delhi did this quite effectively, but then a coordinated system where ambulances can take patients to beds, to hospitals that have beds after telephone triage, as well as a system of mutual aid where if some hospitals are running out of beds, the hospital, not the patient, the hospital or the health system manages and coordinates transfer and mutual aid. During our second wave, we transferred patients up to 500 kilometers away. We received, in my hospital, we received 750 patients in ICU. We ultimately only kept 420 of them in ICU. The other 330 were transferred across the region because we just could not have coped without that. And I think that is another of the things that needs doing. Unfortunately, it is very resource intensive and it is not something that individual hospitals can coordinate. It needs to be done probably at government level, or at least at a regional cooperative level. And the other big elephant in the room is that in a system that is still largely fee for service, transferring a patient out also means a loss of revenue. And how do we deal with that? And that is a really big question. And that is an elephant in the room that I have not heard anyone talk about.
Great.
Rajesh, may I suggest, give you permission? Hello.
Yes, sir.
Thank you, Nitin. Good to see you. And I think you made very important points. I just wanted to add to it. You see, I heard Dr. Rao also. I myself have been looking at it. We have started quite a few things what you are suggesting. I think the live dashboard is that's what we did last year in Gurgaon, where we made a hub of all the hospitals. We knew exactly what was happening within a span of 2 weeks, and we were able to, in the real time, knew which hospital has how many number of beds. But yes, elephant in the room was a very big problem where people are losing revenue. They were talking about that is one. Secondly, we have realized this time is that, as Sumit was talking about, you need to have an army-like approach. You need to have like a war reserve. Here now today you need to have a field reserve, and I think it's a misplaced priority has been put on the ventilators. I think I did discuss with Nitin one. What we are realizing is that majority of the patients you require is a good oxygen supply chain. One, I think should not be a problem with the amount of the oxygen plants which we have gone it now. But nevertheless, we need to ensure oxygen supply chain. I absolutely agree with the Sumit. That's like this time we had problems in certain areas like in NCR or within states. You had like in Maharashtra first in Vidarbha and then coming on to Pune. So that way each state has to have a reserve, complete coordination. And what we have started in Haryana, I think has been presented to Niti Aayog also is, I agree with him, it needs a government intervention. We have now started making field hospitals which have been attached with the CHC, PHC. We have involved ASHA workers into it. And from there, we have a central dashboard. So from the periphery, we are coming up to the sub-tehsil. Tehsil, we are coming up to the district, to the division, and the state coordinator. We learned it from Kerala. That's what he was saying. And we have put into place with the help of Deloitte. And it has been a successful one because if patient is sick, what is extremely important is his family shifted. So it needs a coordinated effort, and it needs a way. Here I will compliment private sector has also come up. The only issue starts coming up at the time of revenue, how much to be given, how much is not to be given. And we have gone a step ahead that we have now started evaluating and doing investigation of these people right at the village level. In the 4 investigation we kept it. That is blood sugar, complete hemogram, CRP, and LDH. It reduced the cost. We picked up, and in that model, when we experimented, 38 people have to post it. So the point I'm trying to make is, if there is a will, that can be done. He talked about Mumbai model. I want to share. We already had made a similar home isolation model because majority of the people, Rajesh, even you must be you have treated number of people, hundreds of people in the home isolation. It was your sane counseling which saved large number of them, and appropriate transportation. So we did it, and the simple model we found out was the urban local bodies, which was also implemented by Mumbai. Later on, we got it done in December, and it has worked it up. But nevertheless, it is a large effort required from all people. And finally, I'm saying the very controversial thing, which I practiced in my intensive care unit, how to cover it up. What we did was, in the medical school in India, we had a very different picture. I tried to use patient relatives, because you can provide the treatment. Who will provide you the care? In our intensive care unit, it is the patient's relatives who provided, supported and supplemented the work of staff nurses. And I compared the mortality between our and the ICU, where it was not there within the same institution. The difference in mortality was nearly 3.5-fold. So the point I'm trying to make is, already you see the pediatrics. What are the data coming from Patna? 50% of the children already are positive when they have antibodies when they went for the vaccination. So probably if it is in the family, which is particularly second wave, we were finding it was across the board in the homes. So use the resource which is there in the family to supplement, to provide care. I think that itself is the trust in the system.
Dr. Xavier, very quick question to you. You manage group of hospital, and one of the factors which you have to tell us, that how did you manage the stress which has gone to the doctors? Because this will be another factor. When we get under stress, our healthcare worker get under stress, and when there is a high mortality, there is a depression, there is a like indifference to the patient. People don't like to manage and they get tired. So all these things. So keep this upbeat. What should be done? What will be the general policy? In general, individual hospital or group of the hospital or head of the institution should take care of the, how should they take care of their healthcare worker, other staff?
That's a very interesting question. Thanks so much, Misra. I think one of the major factors here is communication and maintaining the team effort. I think it's very important to maintain every one of the colleagues that are working like a sports team, right? When we see a sports teams playing and everybody gets to cheer each other and to maintain a very high morale. This has been a year and a half already, pandemic. This is a very intense effort for everybody. I think everybody is overworked in multiple places. When I talk to my colleagues around the world, I'm finding exactly that response. Everybody is tired. And I think it's important to maintain as much as possible communication and acknowledgement to people when they do things. And the understanding, especially that it's not anybody's fault that people unfortunately are dying. So instead of trying to look into, I won't say reprimand, but I will say even being judgmental to your colleagues, I think it's very important to support everyone on their efforts. In addition to that, there are minor things that we have found very important, which is one of them, limit the number of times or the number of hours that people work. And again, it's very important because a lot of us, we have the impulse to work as much as needed and to help until we fall exhausted because of we've done the best we can, but then we don't realize that we're essentially hurting ourselves. So it is really very important that someone controls the time that everybody is making on this, and understanding, again, this is a long race and not a short race, and sometimes the limitations need to be there. So it's not about having more people working, but maybe better quality, and I think it's important to regulate that, despite some of the voluntarism that we find in some people. So those aspects are important. Besides that, of course, we got psychological support that we were able to provide to our personnel, but that's not obviously available for everybody. So I think again, the limitation of hours, the controlling that, and the communication and support is the most important thing we can do with our colleagues.
Excellent, Xavier. Dr. Kapil, the communication is going to play now very important role, because now people have started realizing the disease. They are demanding also visit to the patient. Initially in first and second wave, we could restrict the visit, but probably it will not be possible. So the communication with the family, communication with the team, and communication with the patient, how is going to change in third wave?
already we have learned a lot from the first and second wave, and there is no need to now learn anything. Whatever we are listening, we know everything what to do. Only we have to do it on that. That's the key answer. And regarding the communication now, almost now everybody is geared up for that video counseling and communicating through the digital media. So now I haven't came across any major incidents where relatives were insisting and forcing or creating some rakshak to meet the patient. Now everybody realize how contagious is really. They realize that what is the importance of not allowing them to this thing. So I don't think that is a major issue. Only one thing we should need to see that the major difference, Rajesh, you need to understand that all these patients are with the mobile nowadays. Initially, we were quite stringent or strict with the no mobile in the ICUs, but now in ICUs, wards, these are all with the mobile, and they're communicating with their families continuously. So there is the one good way, or we can learn out of this pandemic, that the mobile actually plays a good way to communicate with the relatives rather than we physically give them that your patient is all right and we are doing everything. So that part is quite now well handled. And if in certain cases, those who are intubated or on a BiPAP or in a critically, where if you show them the relatives, you can communicate through the video counseling, it adds into your comfort. So what we used to do since last more than 1 year, we kept the counseling session as a separate one. We allotted the one consultant for that in between 12 to 2 or 12 to 3. And every day we used to communicate with each and every patient and each and every relatives within that counseling hours. And if suppose in spite of that, if they have any queries, they will upgrade to me for the further communication. So like that, we can have the good system in place. Again repeating, we have everything with us. We know everything about this virus. We have every system available in India. We need to utilize them judicially. And one thing only I will add last, we always talk about the preparations and oxygen supply. Nobody talks about the oxygen audits. I repeatedly telling that saving our resources and utilizing judiciously is more important rather than making them available in large scale. That's what my take-home message.
Dr. Rao sir, the communication, do you think is going to be a little different in third wave? Because we have come across where patient relatives started asking the patient who are on ventilator, who are sick, that they want to wear PPE and want to see the patient physically. They want to go inside. They don't believe that everything is fine on video call. Is going to be more in third wave, do you think?
I don't know, but one thing is sure, that when we resorted to video conferencing, we could only do that with 1:1. So there was only one person on the other side. Okay. And knowing Indians, we have a very strong family bond. And then 5 people wanted a counseling. So that means they expected the consultant to make 5 phone calls. So that is another challenge that is going to be there. It was there in the second wave. It will be there in the third wave as well. Okay. And one thing that I want to ask Rodriguez, and regarding the status of the consent, because now what we were doing in the second wave, we were taking a telephonic consent. So I don't know. I know that the courts will be sympathetic towards it, but what is the legal status of that? Because it was just our saying that we have talked to them and they have given the consent. Unless we were taking a video consent, because that was very difficult to record and very difficult to archive.
Sir, mostly what we were doing whenever we were taking important decisions, we were doing video call and video call on mobile, recording and consenting, and same thing had to be put on soft file. And that's the only way we could do it, because in the middle of night, when everybody's on PP in this issue, so that's what video consulting and agreeing on video call was probably what you could have done, that you can take send the printout and ask the person to take a print, send by whatever way you can send you by WhatsApp. That's what we were doing in some important decision. Yeah, Dr. Deepak, you want to say something?
No, I just wanted to say that during the second wave, we have seen that many attendants are rather barging into the ICUs. They say that we have already recovered the COVID, there is no harm. Yeah. Why don't you allow? And they fight it. They start fighting.
In fact, we had to allow it quite a lot. That's what I was asking.
In third wave,
we'll have more.
We'll have more such requests. Probably almost 50% patients attendant will asked to come inside the ICU.
Yeah. So, Sumit, you want to say something about this aspect, because this will be a new challenge for us to handle in third wave.
I think, as Dr. Kilmani said, we have to live with COVID for a while. So I think we have to allow more physical communication with patient relatives. We have to plan it back to how we do it. And as the data now shows, it's aerosol generating a good mask on the patient relative to come in is good enough. We don't have to put them in PPEs. So I think we'll have to allow more physical contact, communication between patients and relatives now.
Okay. I will come to the last part of my question. Pradeep, is personal protective equipment which we are totally donning and doffing is going to change in third wave? And I'll ask everybody, because it has a relation with resource management, and then we can close up quickly.
If you look at the practice which is going on gradually in the first wave when it came, people are highly cautious about all these things. So they were completely covering them with whatever things is available, they used to cover themselves. But now in the second wave, what we saw, that people changed this, at least the consultants and doctors, they changed their dresses. They said, no, we'll just wear surgical gown and we'll have a cap, mask, and a glass, that plastic frame in front of their face,
Shield.
and face shield. And that's all what we want to. And by the end of second wave, what I saw, that people are going in only these their casual wearings, and not even having properly, other than mask, nothing is there. So things have changed, and I think in the third wave also the same kind of trend will continue, because we have seen, as far as my ICU is concerned, we have seen that 50% of those workers who were working in ICU constantly for more than 6 months, they did not get any infection at any time. 50% only got infected. Just 50% they did not get any infection. So that gave lots of confidence to all the workers, that they got a feeling that yes, if I am vulnerable, I would have already got the infection. Now I'll not get that infection. So this kind of thought process is changing people's mind.
Gloria, your thought on the PP, because it has a direct correlation with the resource management and cutting down the cost.
Yeah. Well, one of the things when we established a response within the hospital, the mission of the incident command system was to protect the hospital and to protect the staff. And if having one person get contaminated or infected implies that person not being in the hospital for 14 days, and maybe other people that were exposed, having them, quarantine and come back. So in terms of protecting our healthcare workers, we were very strict on PPE. And in terms of protecting the hospital, because every time we need to take somebody out, then our hospital system is strained, we're very strict. So for us, our response was at the beginning, everybody who's in direct contact care wears at least an KN95, N95 face shield. And if you're working in the COVID unit, you wear full PPE. Now with the vaccination and the infection rate in Puerto Rico going down, what we're starting to consider is if you have vaccination, and if patients, they have vaccination, we can relax a little bit. We're trying, to get rid of the face shield unless you're going to have high risk procedures, which are, aerosolization in the OR and everything. So we are still, as I think, and I mentioned it in the chat, we haven't spoken about it. I think we can still, we can't put our guard down. And with vaccination, we are, coming ahead. But the game changer will be when we finally have pharmacological treatment for COVID. The same with influenza. And like, I think it was Dr. Rao who had mentioned, it's going to be endemic. And I know it is. And we'll have also endemic diseases, but there's a treatment for that. Right now, we don't have a specific treatment for COVID. So we can't let our guard down. I wouldn't, I'm very proud to say that we had 0 healthcare personnel infected while working. They were infected somewhere else, but not while working with our strict posture. So I think I would be very wary now, especially with new variants, until we have either, medication for COVID. And if the patients bring proof of vaccination or a negative PCR, then you can at least consider lowering your guard down in terms of PPE.
Kapil, quickly, what about your healthcare worker protection guard? Same level, or you are going to lower it? You are muted, Kapil. Kapil, you are muted.
Yeah, right. It was a concern during the first wave, but second wave, it was not a concern, because what we have observed during the first wave, round about our percentage of infection of the healthcare worker was 12 to 13%, and then it dropped down to the 3 to 4% in the second wave. The reason is very clear. We learned where to use PPE and what PPE should be there. It is not mandatory that the full PPE should be wear by everyone, because that affects on your efficacy, that affects on your working hours, that affect on your overall management of the this thing. So we have gone by the whatever the evidence available. Those who are immediate caregivers in a ICUs or in a ward, they can use the full PPE if they are coming across the any aerosol generation procedure. If they are only catering, then they can go ahead with the surgical mask and N95 mask and the face shield. Those who are working in the wards, they can have N95 mask and the scrubs. These are nowadays very routine for us. And those who are working in the non-COVID areas, they can go ahead with the surgical mask or N95 as per their choice. We gave the liberty to them. And it worked very well because it helped us for the management. Because if you're working hours, initially we used to keep the 4 to 5 hours and changing the 4 teams. This luxury is not affordable in India. Even in a corporate setting, in a private setting, this luxury is not possible. So we learn from all these things, and now we are in the good. Even we can have some 8 hours in a ward. We can have 10 hours, and we have enough staff is available. So 2 things are very important: what PPE, where to use, your efficacy, your number of staff, and preventing them in acquiring the infection. Because that what Pradeep is saying, that is overconfident. If somebody is moving without PPE in a high risk area, we used to throw them out, because I don't want overconfident fellows. I can have the dumb fellow which I can train them and take care of that, but I don't want any over smart or overconfident fellow, because that is going to affect my rest of the staff. So this luxury, this type of the behavior, this type of, I am already infected, where I can get infection, please get out from that place. That is what the approach we stringently follow, and we drop down our infection rate.
Javier, your quick comment, because this is very important aspect, because third wave, as is coming, a lot of people will have the thought kind of Pradeep has presented, the thought with Gloria has presented, the thought with Kapil has presented. I want a final comment from you. Is going to be full PPE in high risk, or is going to be modified in different area and as per need? Javier.
Sorry, I couldn't catch the question.
I asked about the PPE. So you heard what Dr. Kapil is saying, what you heard Gloria is saying, what Dr. Pradeep is saying, that now in third wave, it may not be possible that everybody is going with the full PPE. It can be a modification. So are you going to be same stringent for PPE as you were in first wave, or there can be a modification as per need and area? It can change PPE, because it's very important for resource management and cutting down the cost, particularly in the country which are in developing age, where there's no mask available or masks are less. One has to use mask for longer time. So all these resource limitations are also there. So what is your thought for the PPE, full PPE?
Well, I think I agree with Gloria and the fact that we learned about the disease in the last year and a half, and we don't need maybe the precautions that we're using right now to confront the patients. They're completely different to what we had done in the past. So I think the first contact, high aerosol producing procedures will continue having significant PPE's involvement. However, I don't think that we have to go back to what we did about a year and a half ago, as far as this fantastic frantic search for PPE. We know already that this is a droplet transmission. We understand that this is not really an airborne. We got a lot of questions about it. Again, many months ago, I think also there's a little bit of relaxation from the healthcare as far as which is good in this case, as far as what to wear when we contact these patients. So, and we're seeing that. I mean, it's not as easable or transmissible disease as we thought it was. It's not like when you contact the table from someone that was in the room, you're going to get infected. It's definitely a direct transmission. It's definitely crowded transmission, contact to people, but not really. We don't really need to have that kind of a frantic modification of our practice. So I think we'll learn a lot. I think that the use of PPEs has been prudentially reverted a little bit and slowed down, and I think that's the way it's going to be for the future as well.
Good. So we are almost over 15 minutes. So very quick comment I want from Dr. J.C. Khilani sir, and then I'll ask Sumit to comment about overall.
Rajesh, I just wanted to make a comment on PPE. PPE is there, but what type of PPE is there? That is important. Not that what I think I agree with Fernandez. What he said it. PPE, you may be having a gown, no issue. But does not mean that
Sir, you are not very clearly audible. Dr. Dhruv, you are not clearly audible.
What I am saying is PPE are important, but the type, what sort of PPE is the key. So today you need simply gowns like Deepak and his team has been there, Dinana Prangeshkar are there. But what you need to protect is your airways and eyes. That is important, along with simple gown we do, not the type of which we were doing for the direct transmission. Rest everything is needed, but that's all I say.
Okay. And Dr. J.C. Khilani sir, your final comment about the preparation.
I'll be very brief, but you may call me a pessimist, but my thought process is if we are going to have a third wave, it is going to be a mutated virus with different kind of contagiousness and the mode of transmission. So I am very sure about it that as far as the COVID area is concerned, be it the ICU or the ward, the same stringent, strict PP should be worn. In the non-COVID area, one can be complacent and one can go with the N95 mask or a double mask with or without a shield. That's
Sir, I disagree with you. In non-COVID area, we are getting the maximum infection. We have to be as much careful there.
Dhruv, you can disagree, but I have my viewpoint which I already put across.
Okay. Sumit, your thought, because it's very important. Because I don't want people to get complacent about that we had COVID, we have seen 2 waves, we can do this and that. Because you do not know what Delta plus variant, I agree a lot with Dr. Khilani sir, what he's saying, even with Behaviour and Gloria. What is your thought about this? Because very important message we want to give from here about this.
So yes, no doubt we have to be careful as healthcare workers, but I think the most important is the N95 mask. I do not think, because it's an aerosol generating, again, importance of ventilation in your ICU, ventilation in the hospital is very, very important. Along with that, what you wear, I don't think you need a level 3 PPE that we were using, PPE level 3. I think we can work better with less infection, and agree with Dr. Dhruv that actually you have to be more careful in the supposedly non-COVID area because there is a lack of guard there. In the COVID area, because it's aerosol generating, people are much more careful. I would say a level 2 PP with an N95 mask for sure in the COVID area, and in the non-COVID area, double masking for sure. If possible, N95 and maybe just scrubs. I don't think you need a whole gown, etc.
Sorry, I was misunderstood. Please, I'd like to correct myself. I have never said that I said non-COVID area, you don't need a PPE, a double masking and shield will be good enough.
Yeah.
So
that was same convert, sir.
Let me not be misunderstood.
Yeah. You convert same thing. I think there is some mission.
In the
first, let me also speak, bro. In the first wave, there were people sitting in the OPD with the PP, level 3 PP. That's what I said, that's not required. I'm the one who has been shouting aloud right from the beginning that this wretched virus is airborne. So therefore, the mask is the most important. I have no doubt about that. Thank you.
Okay. Dr. B.K. Rao, sir, quick comment about. Your
Yeah, we are basically talking of a difference between the policy and practice. Why we started wearing it? Because of a policy made by the government, policy made by CDC, WHO, and by our own hospitals. Now we are talking of individuals, whether I'm going to wear it or not. So that's the difference, and that is where people should understand that we are now talking of individuals' opinion and not policy, because policy is not going to change.
Okay, Gloria, quick comment about you from you.
Sorry?
Quick comment from you, quick summary from you, quick message from you.
Well, I think the important thing, if I were to put it in a word, it's don't put your guard down. You know, in government, in your personal life, in the administrative part, don't put the guard down. The pandemic is not over. And we still are going ahead. We're better off than we were a year and a half ago. We have a vaccination, but we still don't have a treatment for it. So I think
that's very important. That's very important message for us. We do not have treatment for it. Pradeep, quick comment, and then I go to Nitin and then close. Pradeep, you are muted.
If you look at the study which was published by in Korea about the comparison between second wave and third wave, there was a line which was written, the other routes of transmission, which is unknown routes of transmission. Nobody knows how it gets transmitted. So it is, I know it is, everyone knows that it is an aerosol generated virus which goes from one person to other. Obviously, protection of airway is very important. But, and the second thing, Dr. Rao, what he said, that government policies are very important. Then availability of resources, because mine is a government hospital and resources, many times it is available, sometimes it is not available. So things changes or it gets customized as per the presence or non-presence of whatever gadgets which we need for our protection. So things are there, many things are there. So, and another important thing is that how big ICU you are running, because this time we are running more than 170 patients on ventilator in our hospital. So 170 patients on ventilator, if you are putting, you can imagine how many healthcare workers are involved. And we are having around 750 beds, oxygenated beds on which people are working. So how much resources are required? So there are many things which works behind. I agree with Kapil, what he said here, and I agree with Dr. Sumit also. Everyone has got their own ideas, obviously, but ultimately, what we have to see that we should at least follow the policy which has been made by the government. That is most important. The government says you should have to do like this, you should follow this thing.
Nitin, quick word and then we close after the talk.
I agree with most of the panelists. I think we have to be very careful, as Gloria said, not to let our guard down. But I think also what we need is our hospitals and our regional areas to do a fairly robust risk assessment for different areas. So rather than leaving it to individual judgment on individual hospitals, it's much better if a regional ICU organization or the government or the health department do a risk assessment, and the risk assessment being ICUs, COVID ICU, non-COVID ICU, aerosol generating, COVID wards, non-COVID wards. And then you can have a graded system of PPE. And again, nothing is ever going to be perfect. As Dr. Pradeep said, you have to then come to a balance between personal risk, staff comfort, resources available, your financial capacity in your health budget, essentially. And ultimately, you will come to something that everyone will hate, because that's the very definition of compromise. But ultimately, you have to come to something that is a compromise between all of these things. This is exactly like Dr. Ray was saying earlier, that lockdowns are fantastic for health, or at least for physical health, but they're not so great for socioeconomic health. It's the same with PP. Level 3 PP is great for preventing transmission, but what we need some sort of balance between preventing transmission, staff comfort, and resources. So a graded system with risk assessment, I think, is my summation.
So very quickly, just to summarize what we discussed for preparation of third wave is that first thing we all must understand that we do not have a treatment for COVID. Still, we are evolving and learning. Virus is mutating fast. The new strain, we do not know the severity of illness, what it will be. So if we don't lower our guard, at least whatever precaution we have, at least for mask, avoiding public gathering, that public behavior, appropriate behavior, that is one thing which is going to work and definitely prevent the disease as much as possible. Vaccination, trying to achieve herd immunity is a target. How much it will work, time will tell us, but at least at this time we have a target for that. Proper resource utilization and management, particularly the manpower and resource for the hospital is needed. We need a very strong communication system to communicate between government, different channel, different hospital, and between patients. And proper messaging. New challenges which is probably going to face, that a lot of patients are going to ask for a physical visit to their near and dear ones who are in ICU, and we have to be prepared for that. Consent form probably is going to be another challenge, probably video consent, which is going to be applicable. Lot more will come in subsequently, because in subsequent webinar, we are going to analyze each of these sections in detail and what we spend. Thank you, everyone. Thank you for joining us. Thank you, Kapil. Thank you, Javier. Thank you, Gloria, Nitin, Pradeep, Dr. B.K. Rao, sir, Dr. Dhruv Chaudhary, sir, and Dr. J.C. Kulani, sir, and Sumitre, sir. And at the last is Arindam and Dr. Deepak. If you have anything to comment about, you are welcome to that.
No comments. I would request our General Secretary, Dr. Arindam Kar, to formally close the session. Thank you.
Thank you, everyone. It was a nice learning, and I hope Rajesh would guide us to continue this one. We have certain other plans to connect to you. We have some smaller sessions like Criti Talks, Expert View, and all others coming. So time and again, we would be bothering you and asking you to join with us. And I have already taken up one cue from Dr. Gloria, that the resilience training, which has not been done, a lot of corporates are doing, but we have never done this till this time. But I will connect to you, ma'am, and we'll plan up something on the resilience training. Thank you, everyone, for sparing time for Sunday.